Good evening, friends. Well, at the onset, I must declare I am not a nephrologist. I am an endocrinologist. But obviously, before becoming endocrinologist, I am an internal medicine specialist also. So Vijay has given me the responsibility of discussing about eGFR. So I am going to discuss briefly about eGFR. Now, this is schematic diagram of two kidneys, nephron, Bowman capsule, which all of us know, have read during our first and second professional examination. Now, there is a renal plasma flow which is around 600 to 720 ml per minute. Normally, GFR is around 120 ml. Remember, there are three mechanisms which are responsible for auto-regulation of GFR. Myogenic mechanism, which involve relaxation of afferent arterioles, and tubuloglomerular feedback, and third, activation of RAS system. And why I have shown you this diagram? Because when we come to the therapies to preserve eGFR, there are some drugs which act on efferent side of the tubule. There are drugs which act on the afferent side of the tubule, and it is best to use combination of drug which will act on both efferent and afferent side of the tubule. Also, there is a mesangium where structural changes takes place which will damage your glomerular tuft. So there are now drugs which will handle this structural part of the tubular pathway. Now, if we see, there are many equations which are available. We always tell from last 5 to 7 years since the advent of SGLT2 inhibitor that please calculate eGFR of all your patients. Do not simply rely on serum creatinine. There are many equations which are given. If you does not want to use, all of you are now carrying smartphones. There are free apps available where you have to simply put serum creatinine, age of the patient, gender of the patient, and you will have an automatic eGFR available to you. So just try to use them. Now, why I am saying serum creatinine alone should be not measured? After 4th decade of life, even in healthy individual, there is a gradual decline of eGFR to the tune of 1 ml per minute per square meter body surface area per year. Which means by 70 years of age, more than 40 ml per minute per square meter body surface area of GFR is physiologically lost. Therefore, if you are seeing a 70-year-old gentleman at same serum creatinine in comparison to a 40-year-old gentleman, the purpose of serum creatinine or the interpretation of serum creatinine will be different. So a 0.9 milligram per deciliter serum creatinine at 40 years of age carries a different connotation similar to a 70-year-old gentleman. So therefore, do not only rely on serum creatinine, always calculate eGFR, take into account age of the patient, gender of the patient. They are going to decide about eGFR. Coming to the causes of decline in GFR, when we were students, we were told glomerulonephritis is a leading cause for decrease in eGFR and CKD. But now, currently worldwide, diabetes is a leading cause for glomerulonephritis and decrease in eGFR, followed by glomerulonephritis, then hypertension, and others which include number of other diseases. This is in a diabetic patient, typically initial stage of hyperfiltration, then GFR decreases gradually. If we will not control hyperglycemia aggressively right from day one, at the same time, there is gradual increase in protein excretion from normal excretion to increased micro and macroalbuminuria. What is the prevalence of CKD? This is our own pan-India study. Prevalence of chronic kidney disease in type 2 diabetic patients, where across country we have collected samples, and in this population we have seen, we have enrolled 3,043 subjects, 3,000 were eligible. We have shown 47.8% have mildly decreased eGFR, 15.1 has moderate, and so on. And not only that, we have assessed microalbumin. So when it comes to eGFR, also assess urine albumin level. Now, based on these two parameters, eGFR and albumin level, you have to risk categorize your patient. Now, based on eGFR, there are categories of CKD. 3 and below is defined as CKD, that is less than 60. Similarly, albumin excretion is A1, A2, A3, where A1 is less than 30 milligram per gram, A2 is 30 to 300, which is a microalbuminuria stage, and A3 is more than 300, which is macroalbuminuria stage. Now this is a table which is nowadays available on net. You can keep it on your table. Now why it is important? Both the parameters are important. If whatever is seen is green is good, and whatever is shown in orange and red is bad for the patient. Now it is very simple. You have calculated eGFR, you have assessed albumin excretion, and see at same level of, how to move it back, at same level of albumin excretion, if your GFR is different, patient is in different risk category. How to highlight this? Okay, I got it. So say for example, patient eGFR is 60 to 89, but patient albumin excretion is in A3 stage. Patient is in macroalbuminuria stage. Now this patient has come into a risk zone. In contrast, even with an eGFR of 60 to 89, if albumin excretion is in A1 stage, patient is in green stage. So it's risk categorization based on eGFR and based on albumin excretion in a particular patient, change the therapy. What are the factors affecting progression of kidney disease? Number of factors. Simple obesity is a risk factor for development of CKD. Age, I have told you, as we ages, there is a decrease in eGFR normally. Diabetes, race, ethnicity, smoking, hypertension, hyperglycemia, cause of CKD, dyslipidemia, presence or absence of cardiovascular disease. So lots of diseases are responsible for causing CKD. So when it comes to prevention of decrease in eGFR, there are two approaches. These two approaches are indirect approaches, which means you target risk factors like aggressive control of hyperglycemia, hypertension, hypervolemia, dyslipidemia, and direct targeting the renal dysfunction, which will decrease your eGFR, which will slow down the decrease in eGFR, and which will reduce albumin excretion. And this is how, based on staging of and natural history of the disease, we can do screening, risk factor modification, diagnosis and treatment of the patient. Now the first is, we will discuss only direct, the drugs which are acting on kidney directly. If we see last 20 years, from 2000 onward, we have ACE and ARBs. I will not discuss in detail about these trials, Renin trial, IDNT trial. These are standard of therapy for all patients who have developed CKD. But remember, ACE and ARBs act only efferent side of the tubule. They does not act on afferent side of the tubule. They does not have any effect on structural damage which is going in the kidney. So lots of unmet need is present when it comes to prevention of CKD and reduction of eGFR in diabetic or non-diabetic kidney disease patients. So next evolution comes with SGLT2 inhibitor. And this is a diagram to show the projection that if at the age of 63, eGFR of 56, if you prescribe SGLT2 inhibitor, irrespective of presence or absence of diabetes, what is going to happen? A patient of diabetes, the projected decline in eGFR is 4.59 per year, which means in next 10 years, this patient will require renal replacement therapy in form of dialysis or transplant. But when you add SGLT2 inhibitor timely, what is going to happen? The decline in eGFR is reduced to 1.85 ml per year, which means patient will get an additional 15 years before he is progressed to renal replacement therapy. So SGLT2 inhibitor after 20 years is a new drug which is acting on afferent side of the tubule. ACE and ARBs are acting on efferent side of the tubule. SGLT2 inhibitor are acting on afferent side of the tubule. So now we have another drug, and these are number of mechanistic pathways which I will not discuss in detail, but have a look on this slide. There are large number of reasons because of which SGLT2 inhibitor has to be used in a patient of CKD irrespective of glycemic status. Remember, irrespective of glycemic status, and they are recommended to be used in all patients with eGFR up to 20 ml. We have now studies and data that up to 20 ml they are safe, effective in reducing progression. But despite use of SGLT2 inhibitor, still large number of patient still progresses. So there is a unmet need to address the structural defects. So there is another drug, Finrenon. There is an entire lecture on this. Finrenon is a non-steroidal mineralocorticoid receptor antagonist, and it has been shown there is an overexpression of mineralocorticoid receptors which are responsible for fibrosis, apoptosis, inflammation in renal parenchyma. And based on Fidello study, Finrenon is now approved for use in patients of CKD to reduce progression of the study. So friends, we have now 3 different class of agent. I am going to stop in next 1 minute. We have ACE and ARBs which act on efferent side of the tubule, hemodynamic effect. We have SGLT2 inhibitor which act on afferent side of the tubule, have hemodynamic as well as number of other benefits. And we have Finrenon which has anti-inflammatory, anti-fibrotic effect in preclinical model and are found to have reduction in albuminuria independent of changes in BP in patients who are having type 2 diabetes and CKD. So all 3 pathways are blocked if we are using combination of drug. So the future, what are the gaps? If we see, can we use combination of Finrenon and SGLT2 inhibitor? In the trial, very small number of patients were assessed who were having both Finrenon and SGLT2 inhibitor. But understanding their different pathophysiological mechanism, it seems combining them is going to be beneficial, but we do not have any large-scale randomized trial to answer this. So dual therapy has a role in current treatment guidelines. Can 3-drug class means combining RAS inhibitor, SGLT2, MRA in patients of CKD and type 2 diabetes are going to provide further benefit? Again, this question is going to be answered by future randomized controlled trial in this. So I will like to stop here by showing this quote, fresh thinking rather than predetermined or predictable thinking is required, because practicing medicine is an art of interpretation of science and its application to human health, behavior and disease. Thank you very much.